Good morning, and welcome to the panel discussion, Converting to mHealth, How to Drive Change. My name is Eric Wickland. I'm editor of mHIMSS.org. I want this to be a very interactive panel, so what I'm going to do is introduce our panelists. They can tell you a little bit about themselves. I've got a few questions or topics that we'll get into, and then if you've got any questions, feel free to come up and we'll just get the ball rolling here. My panel consists of Alan Portella, Airstrip Technologies. Next to him, Alex Nason from Johns Hopkins Medicine, Geeta Nayar from AT&T, and Michael Korachek of Ear, Nose, and Throat of Georgia. So why don't I just pass this on and
My name is Alan Portella. I'm the CEO at Airstrip Technologies, and what we do is medical device. We started with medical device mobility, basically connecting to re-rendering data from medical devices like patient monitors, fetal surveillance monitors, also EKGs, and we connect now patients from the ambulance to all the way through the inpatient facility, looking at emergency departments, ICU, step-downs, again, patient monitoring, cardiology. We are FDA cleared and recently granted a very nice methodology patent to mobilize medical devices. And about 6 months ago, we acquired the IP for a mobile EMR extender, taking the same approach, basically mobilizing all the EMRs regardless of the source. So basically bringing data from Cerner, Epic, Meditech, and providing one single view, seamless for the physicians throughout the continuum, looking at medical devices and EMR. So we are, just to close on my introduction, everybody's saying that we are the ones that brought mobility in healthcare as a must-have. And today, hopefully, I will be able to deliver a message on how we did it.
Good morning. My name is Alex Nason. I'm the Director of Telemedicine and Interactive Learning at Johns Hopkins Medicine. I'm the guy that sits in between all of you. I sit between the physicians, I sit between the technology groups, I sit between IT, and I try to translate between the different groups and their desires. At Hopkins, we're involved on the telemedicine aspect, and mHealth is a part of that. Everything from an EICU applications to telederm, teleparkinson's programs that we have going on, telestroke. And then also on the educational side, I think there's a great opportunity on the mobile platform for the convenience of getting all your compliance and training done through the mobile platform. And so we're looking at building applications and educational training for the mobile space. It's an interesting space for us because it's quickly evolving, and we've changed as an organization as well. We weren't a large integrated system that long ago, and now we have hospitals coming down here to Washington, D.C., as well as now a children's hospital in Tampa, Florida. So we're now also embracing the need to be more engaging with our hospitals that we have here in the U.S. as well as our international platform.
Thank you. Good morning, everyone. Thank you for joining our panel today and for delaying your flights to be here. We appreciate it. My name is Geeta Nayar. I'm the Chief Medical Information Officer for AT&T. I'm also a practicing physician and a rheumatologist. Deal with chronic diseases every day. I'm a big believer in breaking down the barriers that the four walls of the hospital cause for both patients and providers, and very privileged to be working at a company like AT&T that believes in that as well. Also just want to thank Eric and mHIMSS for the opportunity to be here. Thank you so much.
They left me with a microphone all to myself, and that's not a good thing, I promise you. My name is Mike Korachek. I'm an ear, nose, and throat physician from Atlanta. I describe myself kind of as an EMR evangelist. I go to my fellow physicians and I say, you need to consider this technology. It can work for your practice. It can be a good return on investment. We've got the numbers to prove it. Then I also go to IT audiences and I say, you know, the product is not quite as ready for prime time as everyone thinks, and that there's things that you need to do to make things better so that physicians can actually use this to better their practices and their patients' lives. We've had an EMR for 8 years. We've been very, very successful with it. We are just on the cusp of looking at mHealth technology. So if there is a target audience for your products, we're it.
All right. Well, the title of the session basically is very open-ended, how to drive change. And that's kind of contingent on the fact that people actually want to change. A lot of the conversation I've been hearing in the last few days is and something we discuss in a breakfast panel discussion on the first day, is that physicians are kind of reluctant to embrace mHealth right now. They've got too much on their plates. They don't see it as something that's going to help them out. So I'm going to start with the basic question: and why are physicians reluctant to embrace mHealth?
I didn't realize I was going to sit first. I took the second chair hoping that somebody was going to sit on my right. So, like everything else, if we don't improve workflow, if we don't improve care coordination, then physicians are not going to adopt the technology. I think that if you look at the last 10 years on healthcare information technology, I think that we all are guilty of leaving the physician for the last one, because physicians, everybody says that they're very difficult, but the issue is that we don't provide user-friendly tools to help them. So the reality is you have to look at transformation, and you have to realize that technology is not going to drive transformation, clinical transformation. Technology is just an enabler. So you need to start understanding their use cases, their workflow, and you need to start aligning that with process. So people and process need to be aligned with technology. Technology, again, is just an enabler. So if you're looking at transformation, you have to bring information, interoperability, and you need to be aligned with their incentives. And if you take those three things and you figure out a model, then you can bring technology to them.
Sure. I'll just add to that if I can. When the stethoscope was first developed, a lot of doctors weren't jumping up and down to say, hey, let's use that big plastic tube and put it on patients' chests and listen for air sounds. Stethoscopes really revolutionized the way doctors practice medicine, and now you can't imagine going into an examining room without the stethoscope around your shoulders. And I would kind of challenge the idea that physicians are reluctant to use mHealth. I think when technology is used as an enabler, I think when technology makes sense and connects patients and providers in a way that paper-based systems do not, physicians are more than happy to use mHealth technologies, but when they're an impediment, when they don't work with the workflow, when they don't make sense for their patients, they're not going to use it, and they're definitely not going to use it. I'm not going to use it as a physician if it doesn't make sense for my patients and for the practice of medicine. So the more that mHealth is an intuitive technology, the more simplistic it is, often actually is a more elegant utility tool, and to the extent that it actually enables care is really what we're talking about, I think, in terms of driving adoption.
I think also what we found is the mHealth industry right now is still about a new technology or a new app or a new device, et cetera. I think in the telemedicine space, from their history, 10 years ago, the floor was all about devices and boxes, and now it's all about services. And I think over time, the industry is going to shift to how is a service being delivered differently, focusing on the outcomes that we were talking about here. Because I think one thing that we miss is that it's not about the box. It's not about the app. It's how we engage with our patients. It just happens to be, like you said, the tool that we happen to be using for that. So I think that's one of the missing points. Another point is also, not everyone gets it, and that's okay. People in this audience are here because we can kind of see the future, or we're engaged in the future and seeing what it's all about. Others aren't interested, and they'll come along kicking and screaming slowly eventually.
I agree with all that. I'll put it a slightly different way. I think it breaks down into three issues for me. The first is that there's not enough of a body of evidence that demonstrates that any health information technology, when we talk about EMR or mHealth or whatever, that it's going to be an effective method of practicing medicine and improving patient care and improving our bottom line once we spend a huge amount of money on this technology. If you look at start with an EMR, we're supposed to spend $250,000 on an EMR, and at least to the second point, there's no business model for how we're supposed to bring this into our practices and even recover the investment. If all you do is buy it and follow the instructions that your vendor gives you, you're going to end up $250,000 in the hole, plus the increased staff costs, and no one shows the way on how to recover that and make a return on investment. We figured it out on our own, but there was no one there to tell us how. And the last part is that any change to the practice of medicine is going to have unintended side effects. And nobody seems to be acknowledging that. It's all about reducing drug errors and all that kind of stuff. Well, I think, if you use this every day, you would agree that it doesn't eliminate errors. It just replaces errors that we're familiar with errors that we're not familiar with. And no one seems to acknowledge that. Starting with CMS and HHS, where they're saying the benefits are obvious. If you don't get this, you're an idiot. And docs aren't going to respond well to that.
So, can I just, I'm sorry, I just got so excited. I'm going to grab this like this now. So, thank you. I don't know you, but you just set it up for me to jump in. So that's the key. First of all, I spent 20 years selling EMRs, and the reality is that EMRs are just an operating system like it is to your PC. You cannot spend millions of dollars on your OS for your PC. You benefit from the apps that you run on your PC and the technologies that you plug in to that. So EMRs are just a commodity. And finally, the industry is getting that. Now, when it comes to innovation and ROI, every time there is a new technology, all of us vendors, we always go, who is going to pay for this? Who is going to reimburse? How are we going to get paid for this? And the reality is that moving forward, since everybody is reducing cost, what we need to realize is that we as vendors, we need to bring the value. And this is what we did, and this is how we became who we are becoming today at Airstrip. We looked at the challenges in the industry, and we said, okay, why don't we just start in one area to try to make an impact? And we started saying, let's look at CHF. Let's look at cardiac events. And that's what we did. We said, okay, a patient with a STEMI, full blockage in the artery, comes into the emergency department. They get picked up by the ambulance. What can we do there? And then we recognize that the standard in the industry, in the country, is 90 days from door to balloon time, ED to cath lab. And we said, what can we do from the ambulance? And we ended up providing the EKGs with a resolution that they never had before to the cardiologists. And now we reduce event to balloon time by 35 minutes instead of 100 minutes if you count the ambulance transport. So then by doing that, we started saying, whoa, 35 minutes, you have a healthier heart. But also we reduce false activation of cath labs, because many times you prepare the whole thing and it's not a STEMI. And then we started seeing a reduction of length of stay by 0.85 days in the ICU for a patient with a STEMI. And we went on, and we realized that there were savings all the way through the ICU, and step down and after, it was all reimbursement models that were coming in. We were able to quantify that, and we said if we charge 10% of that, we should be okay. And we did that. We have over 60 hospitals since we introduced this in 12 months. In the OB, we did the same thing. We were doing risk litigation, management, and basically today we cover 700,000 babies every year out of the 4.5 million that are born every year. So everything we do, we look at the value prop and we measure it on a daily basis.
If I could just add to that, I think you brought up a great point with regards to evidence. With any new industry, with any new technology, everyone says, where's the evidence? Well, we didn't have all this stuff 5 years ago, 10 years ago, or 20 years ago. And so I think that's part of the reason a lot of us are here. I think as an industry, as mHIMSS, as the summit, we need to be thinking about evidence. And what the evidence is clear on is that the way we practice healthcare in today's environment is not sustainable, not cost effective, and not delivering quality care. So, I think for all of us that are here, we have to look to the evidence that's out there. We as a company have invested in several pilots where we're seeing good outcomes. Johns Hopkins is here. They've done all kinds of studies. So I think that we need to, as an industry, look at that as the industry develops and find the evidence, because I think we can all agree that it makes sense, and we'll find it. We just haven't necessarily done the study yet.
And I think the model of evidence also, as Joe Cavador mentioned yesterday, has to change. We can't do a 5-year double-blinded 50,000 people on using an app and 50,000 people not using the app and waiting it for being JAMA for people to accept it. The technology is moving so fast. So we need a new way of demonstrating what that evidence looks like that the industry, the medical providers will accept as well. Because we know that, hey, 20 people used it, we saw some quick outcomes, and you see these presentations of 80 people. It's just not enough for large organizations, and that's one of the struggles that we have at Hopkins.
I wonder about that a little bit, only because you do have to have some methodology that we trust. So I agree, we've got to come up with a way that's faster, but my fear is that in the pursuit of speed, that we don't have the quality of the evidence, and then we end up getting, sort of unexpected, unintended side effects, both to the standards of care, right? If you're monitoring CHF at home, what are the standards? How often do you monitor? What do you do? What's the liability there? We don't understand what the liability there is if there's an adverse event of someone who's in a monitoring program. But yeah, we need to build a better mousetrap. But I think we've got to be careful that we don't make speed the altar we worship at the risk of.
But we need to find the middle ground, because what happens is we're moving into a patient-centered approach. We're adding 38 million patients to the system. We don't have enough doctors. We have a mess. So we need to find that middle ground, and we need to make sure that the 50,000 patients that are not going to be on that blind study, that at least they benefit and they don't die because we're not paying attention to that.
The promise of mHealth, as we discussed it in a conference call, is that it fills in the gaps in care. Could you explain a little bit what those gaps are and how would link those care moments?
Sure. I'm happy to take the first one. I have a feeling that some of my colleagues have more to add. The average office visit right now is about 8 minutes. In 8 minutes, I've got to deal with my patient's arthritis, their lupus, their diabetes, and their hypertension. I'd like to think I'm a pretty good doc, but the reality is there's only so much you can accomplish in 8 minutes in any conversation, clinical or non-clinical. And I think the promise of mHealth is just that. It's taking that office visit from 8 minutes, from the barriers that we all experience within the four walls of any room, whether it's a hospital room or a patient's examining room, and saying, look, let me meet you in your home. Let me meet you where you experience your health care, where you experience your diabetes, because it's at your dining table, it's at your kitchen table, it's in your gym if you choose to go to one, it's at your office if you work. And so I think that the bottom line is that we're taking the idea, or the antiquated idea of the house call, and taking that big black bag that doctors used to carry to their patients' homes and saying, let's carry a smartphone, let's carry a smart tablet. Let's go to the patient where they actually experience their care, which is not in the doctor's office and not in the hospital, and certainly should not be, right? That's the whole idea here, is that we don't want people to have acute, expensive, poor quality events that are leading them to the hospital and the emergency rooms. And that's really the gaps that we see today, and I think the promise that's out there.
So, very good point. So to add to that, if you look at, everybody says, well, the EMRs, everybody's trying to spend time to really cover the gaps of the EMRs. There are two types of gaps. One is features and functions, and the other one is physician workflow. On the features and functions, good luck. That's going to be there for the next 50 years. It's been like that for 15 years. And the solution that people find is they say, okay, I'm going to get rid of this one to get the new one that everybody's talking about, and they bring new EMRs. The reality is hospitals are consolidating, and now you cannot afford to put everybody on one EMR, because even if I had 50 hospitals with one system, I'm about to buy 40 that have all kinds of things, and I will never be able to move everything. So features and functions is a different story. What mobility brings is we cover workflow gaps for physicians. So what we need to do for those caregivers is to be able to mobilize their most important clinical data sources. And I can give you some. I tell you, medical devices throughout the continuum, EMR data, imaging systems, video conferencing, secure messaging. Those are components that are going to impact the workflow significantly. And we have to realize we have a huge shortage of caregivers. Primary care doctors are going down, specialists are going up, but not enough to take care of the patient population. So the reality is that they are becoming mobile professionals. You need to take the data to them rather than them to the data. 5 years from now, we're going to see a picture as a comic thing, some physician on a desktop trying to find data and document data. Mobile technology is the way.
Two thoughts to add to that. The gaps that I see is similar to what you were saying. said slightly differently, is I'd like to see more bandwidth between me and my patient, which is kind of a different way of saying the same thing. All we have now is the office visit, and I'd like to be able to add other things. The biggest barrier to that is funding, which Alan already talked about. If I talk to a patient on the phone or we interact by a secure portal and I try to bill Blue Cross for that, all I'm going to get is laughter. Right? And so, you can invest in all this infrastructure and do all that stuff. If there's no revenue stream coming from what you're doing, it's not going to go anywhere. And it's illegal in many cases for me to balance bill patients for that. So you can't say, I'm going to do this concierge feature and I'm going to bill patients extra for it. You may have either your insurers with their contracts or the government coming after you and saying, well, you can't, especially if you do it with Medicare patients, that you can't do that. You have to accept that office payment as the only revenue that you're going to get. So, getting back to the physician reluctance question, if you're asking docs to substitute work that generates no money for work that is generating, a reimbursement, of course that's not going to be well accepted. There's got to be a way to get paid for that work that you're doing.
Unless, of course, you're motivated by under some type of capitated program or accountable care organization, where you're then motivated to keep that patient healthier. So, hey, spending a little bit of money might end up offsetting and keeping more of the pocket.
Well, in theory, yeah, exactly.
In theory, I know.
And again, coming from a fairly long experience with capitation and managed care, the devil's in the details. And yeah, in theory, it's easy to talk about aligning incentives. In practice, it's a far more complicated thing.
I think there's also opportunities in the mobile health space, along with the services that we've talked about before, but also patient satisfaction as a way of engagement. Engagement not only with their health, but also engagement with the practice itself or your organization is an opportunity. Organizations are starting to be tracked based off of this thing called patient satisfaction, but yet there are pieces of paper that get handed to somebody that gets shoved into the bottom of the bag on discharge. So hopefully mHealth could also play an aspect with just trying to capture more of that data.
I just wanted to pick one area, because we were talking before about the transport and ICU and home. Just one area that people will say, what can you do with mobility? Let's look at step down. After you were in the ICU or intermediate care, you go to the step down area. So when we came into a hospital, what we did, and actually we did this at several hospitals, not with 50,000 patients, but we tried to find a middle ground. And we took, at each of those facilities, 100 patients that were already discharged over the last 12 months. And we put those EKGs on an iPad, and we gave it to cardiologists. We detected 7% of those patients had dysrhythmias that were not detected by the doctors on the floor, because they're not cardiologists, and those patients were sent home with dysrhythmias, not detected. Then we looked at the track, and many of those patients came back within 30 days. But also, we realized that depending on the state, you can get anywhere between $30 to $70 just if the cardiologist signs off on the discharge for you to go home. That right now, they're not getting that money. Of course, if I detect that 7% of those patients have a dysrhythmia, I need to perform additional analysis on those patients that will bring additional revenues on reimbursement that I was not even looking at because I sent them home. On top of that, I will be penalized now if it is a cardiac patient. So if you look at every area and you look at the workflow and you just don't think of technology, just, oh, I'm going to throw that up and hopefully it helps them. If you really work with the physicians and the caregivers to figure out the value proposition, you're going to be amazed. And we are going to look at publishing soon, and we're engaging with a number of organizations. Already, Qualcomm gave a grant to Dr. Eric Topol to start working on some of our accounts so we can start publishing on this type of thing. So definitely there is a benefit there.
Alan, you mentioned before about some of the difficulties large providers are facing because they're trying to integrate different EMRs and how networks are coming in with their EMRs. How can we use mHealth to get into that EMR equation when you're talking about large providers?
Okay, so what happens is we know that healthcare organizations right now that we're moving into an outcomes-based model, volume to value. what happens is they're cutting cost, and they're right now, as they're cutting cost on the inpatient side, they're buying more physician groups, and they're buying some hospitals in some regions to be able to bring more patients into the system on specific service lines, cardiology, endocrinology, etc., depending on the chronic disease. So we have to realize that if one of the big initiatives, you look at Orlando Regional, they just announced that they're laying off 400 people, but at the same time they're spending $50 million buying physician groups. They're buying the physician groups to be able to manage that population health and be able to attract those patients to their systems. So the first thing you need to do is, to the physician, while you are taking care of our patients, don't worry, we are going to figure out the back-end integration. We are going to optimize what we have, but we don't want your practice to suffer, because if you do that, then you lose those patients because you become very inefficient. So you have to look at that as two parallel things. I'm buying physicians. Physicians are important to me. I need to provide them with the tools so they don't see the mess that I have behind the scenes. And the only way to cover that is by commoditizing all those back-end data sources. We did it with medical devices. It doesn't matter if you have Space Labs in the emergency department, Philips in the ICU, or GE on step-down. For the doctor, the waveform looks the same way, and the lab data and the charted data looks the same way. So you need to deal with physician workflow while you figure out the back end.
I think this whole thing with workflow can't be overemphasized. This is what we had to figure out on our own, because neither our vendor nor anybody else that we could find really understood what it took to bring workflow online. Because what does an EMR allow you to do? It allows you to codify and automate workflow. But physicians' offices don't understand their own workflow. A lot of docs' offices don't even have workflow. What docs have relied on historically is, that one administrator, that one staff member, that one nurse that sort of kept it all straight in his or her head. But that's a very difficult thing to codify. So when we got comfortable with our EMR after a year or two, we said, okay, we need to look at workflows and first off standardize them and recognize sort of what we're doing informally, formalize those things, and then leverage the EMR, the automated phone system, and remote access to make those workflows more efficient. And that's where the return on investment came from. I think to the question of bigger groups, if you're bringing those in, I think you probably need to approach that at a local level and sort of give docs a way to control their own destiny. Because if we get the sense that we're being bought out by a big brother and the stuff that's coming in is kind of a my way or the highway thing, you may get what appears to be buy-in, but you will not be making people happy.
Can you use mHealth as a way to attract or to bring these smaller groups into the network?
If you can demonstrate value. If you can demonstrate value, that's what does the doc need? The doc needs an ability to acquire the technology and get the return on investment, right? And then it depends on who's spending the money, right? If a big group can bring those devices to a doc without the physician laying out their own capital, which is very scarce, then that would help. But in the end, you got to show it's good for your patients and it's good for your practice. And then third, but not unimportant, is good for the bottom line.
I think also culture is important. I think these large organizations like Johns Hopkins that are purchasing these smaller practices and bringing them into the fold can't drive the same kind of culture that we have at a large academic medical center with a smaller community practice that's now part of the network. And so I think, again, throwing boxes at people isn't going to make a lot of sense. So there's value-added services to make them part of the organization I think could bring value. But you got to know that culture. Years ago when the whole physician hospital organization popped up, which I think this is what we're doing again. But when we did that, hospitals showed up and said, here, use our system, use our billing system. It was a hospital system for a private practice, and everything sort of fell apart there. That culture, that environment wasn't appropriate. So I think understanding the value-added services is important, but also knowing that community practice of 20 docs, a cardiology practice that's been purchased by a large integrated health system isn't always a perfect match from one system to another.
I'm sorry, no, go ahead.
To the point you were making, we just had a presidential election, and it's always the economy stupid, right? So in health IT, it's the workflow stupid, right? Like, it's got to match the workflow. Physicians are not going to use technologies, mobile health or otherwise, if they don't work in their day-to-day practice and make things intuitive and simple and elegant. But it is also a little bit like you were asking us, Eric, in terms of can mHealth lead some of this? And I would say absolutely. I mean, I have patients that come to me and show me the latest and greatest app. I have residents in training, doctors in training that come in with very cool applications and technologies on their smartphones or their tablets, and are basically so used to using these devices and everything else they do, whether it's making restaurant reservations, banking, staying connected with their friends and family and their colleagues. So when they step into medical school or they step into a healthcare environment, the question becomes, well, why can't I use this thing to do, the practice of medicine? So I think that some of this is going to be coming from the consumer, coming from the mHealth space, and driving the revenue, the ROI, and the workflow to make sure that if we're introducing devices like this and technologies like this, that it makes sense for the doctors, big or small. And again, doctors, provider organizations, big or small, are businesses, and they have to know that there is a value proposition financially as well as in outcomes as we look at the health reform landscape and the ACO model as it comes to fruition. So it all really goes together.
So I wanted to share an experience that we're going through right now. One of our customers, a very large healthcare organization, has been using OB, obstetrics, fetal monitoring remotely for about 3 to 4 years. And now they want to expand all their facilities to the EMRs and also to look at patient monitoring and cardiology. They are my partner. And we're going through an amendment to add this to the contract, and then they said, we will sign in 30 days, but in the next 30 days, you need to go to the physician community, not just the C-suite at the corporate side. You're going to go into that region where we're going to start this, and you're going to talk to the primary care doctors, the hospitalists, and you're going to talk to the specialists, and you're going to come with them. And if they want it, we will do it. This has never happened. I've been in 20 years in healthcare. C-suite always made the decisions, and they never really consulted with the doctors. And the doctors actually didn't get engaged on the process, even though they were invited. So the reality is we are experiencing transformation because the sense of urgency has been established, and we all need to work together.
I'll second that. When I go to physician audiences, I say, look, you can't throw the baby out with the bathwater. Health IT's got some issues, but you've got to buy in at some level. And yes, docs have been invited to some degree to these conversations. And yes, as a group, we choose not to go. And my message to them is, you've got to get engaged, because if we don't participate, it is going to happen without us. It did 20 years ago with managed care when we all folded our arms and said, well, health care is expensive, deal with it. I think that was a terrible mistake. And I tell docs we can't repeat that mistake again. But the flip side is that the products aren't quite ready for prime time either. And the story I was meaning to tell at some point here, I'll just tell it now, is we were talking with our web portal vendor a couple of months ago. We have monthly meetings. We're still kind of on the implementation ramp up. This is our second web portal vendor because our first one after 5 years still had a worthless product, and we had to drop them because it didn't work at all. And it was our EMR vendor's favorite son in terms of the vendors. They said, you want the best one? Go here. We went there 5 years. It was a disaster. So we got another one. And so we're still working on some issues, and they come to us and say, well, we've got a mobile app now. Why don't you buy the mobile app? It only costs you $10 per doctor per month, and you can have a mobile app. And I said, well, that's great, but we don't have the core application working yet. Okay, and we don't, and they don't understand that if the core application doesn't work 100%, we have no ROI, right? Our core application, right? The point, and you're all familiar with this, is that if you have a web portal that allows patients to enter their demographics and their clinical information themselves, not only will it be more accurate, because they're going to be far more compulsive about that than somebody who's copying this off a sheet of paper. You're not duplicating work. It's obviously a win-win to have patients enter this stuff. We're still working on the demographic side. We're about to get the clinical side up. But on the demographic side, half the fields the patient enters aren't coming through. They're not pushing to the EMR. And, you get all kinds of explanations. Well, we just bought the vendor that provided the code, and now we're going to learn it, and we'll have this working by January, February, even though we bought the thing last May, and this is the, I mean, if I said the name, you would all recognize it as one of the big players in web portals. It's not some peripheral player. And yet, you know, you get all these crazy explanations when you thought you bought a totally mature product. And it turns out it's not everything it's cracked up to be. And like, well, that's no big deal, right? And it was like, well, no, it's a huge deal because I can't redeploy my front office staff that is currently entering demographics manually. I can't redeploy them. I mean, if they have to enter 3 fields that don't pull over, I may as well have them enter 20. Because it's, you know, if they got to open up the EMR to enter that stuff, I can't redeploy those people, so I get no return on investment. So I had to have that big speech. I said, fine, when you get the core app done, I'll talk to you about the mobile.
So, sorry, go ahead.
You know, I think that healthcare is a very special industry, and maybe that's because I've been in healthcare my whole life. But I don't think that healthcare is an industry that can be transformed from the outside in. I don't think it will work. I don't think it has worked in many experiments that have happened throughout the industry for a long time. So if this is going to work, it has to come from the inside out. How many folks in the audience are doctors, nurses, providers? I'm just curious. That's great. There's 2 of us, I think, on the panel here today. And
there is one that didn't raise a hand, right there.
All right, there we go. You know, we as an industry have to change that paradigm, and whether you're on the vendor side, whether you're on the payer side, the provider side, and so forth, the academic side, you have to have the clinical leadership. You have to have physicians, you have to have nurses, you have to have people who touch and deal with patients every day and deliver care on the front lines. Without that, this stuff is not going to work. I mean, just yesterday, someone was talking to me about a gamification tool that would help patients with osteoarthritis. And I just looked at them and said, well, you know, I deal with 75-year-old patients with osteoarthritis all the time. And they can barely, you know, get their phone out of their purse. So I'm not sure that a gamification tool for a 75-year-old with osteoarthritis is the best place to invest in right now. But if you were to invest in a gamification tool that would help a 19-year-old pre-diabetic get up off the couch, get out there in their community, play soccer, play baseball, you know, do all the things that are good for your bones, joints, and heart, you know, that would be a great place to invest, right? So everything we're talking about, I think, has been great in the past few days, but at the end of the day, you've got to have the clinical leadership. It's got to make sense for the patient and doctor, and not just at a superficial level, but at a very real level. And again, I'm seeing that day in and day out in my practice, whether it's coming from the patients, whether it's coming from the other doctors I work with, and the folks that are going to lead healthcare in the next generation. They're not going to use a clunky tool or portal. And if you're looking for, you know, the entrepreneurs out there, I think, again, it's going to come from the physicians, it's going to come from the nurses, and it's going to come from the people who actually do this stuff every day.
And to add to what she's saying, also you have to change your buying patterns. Because the way things are in healthcare for the last, since Y2K, where everybody thought that everything was going to explode and they need to go with one vendor, the buying pattern is that you buy from one vendor and you get their son and all the things that they bring to the table. But I'm going to give you a projection over the next 5 years of what the world will look like if you continue buying this way. I wish all the hospitals in the country could be connected to what we're saying right now. So in the next 5 years, you're going to have 50 healthcare organizations that are going to own every hospital in the country. There are going to be 50. And the way it's going to look on the back end is that you're going to have multiple vendors, the top 3 or 4, that are going to cover all those places. If you continue the buying pattern of buying from them, Cerner will sell you their EMR. Epic will sell you their EMR. McKesson will sell you the EMR. And then what happens is the doctors will end up getting a reflection of the mess that already exists now on their cell phone, and they're going to throw it away. I already did mine the other day, and I crushed it. So the reality is that if you do that, you're going to extend the mess, and it's going to be even worse. So what happens now, you need to rely on new partners, bless you, on those innovators. The companies that are coming in to solve a problem, they are innovators. You need to put them along your side, and you're going to say, my politics are a mess, my buying patterns are terrible, but just hang in there with me. We're going to work with the users, and we're going to get you in, and we are going to work through this challenge. But you need to change the buying patterns.
Okay, think we're hearing that the small practice physician is going to be swallowed up by big corporations. Yesterday, I think we heard that the physician himself is going to be replaced by a computer eventually anyway. Let's talk about apps for a minute. As a physician, how would you use an app?
I think not, by the way. I think not. Anybody who wants to be a patient to a computer, go for it. I don't think it's going to fly, but if you want to make yourself the guinea pig, be my guest.
Exactly. I can't let that comment go. Sorry, Eric. And I think this whole notion that the doctor's going to go away and patients are going to go to a robot and feel really comfortable talking about their chest pain and their sexual history, and not going to happen. I think that's the opportunity with mHealth, actually. It's not to depersonalize the patient-physician relationship, but actually to personalize it. I mean, I've seen you guys walking around here. I've seen bedazzled phones. I've seen the color of your iPad and iPhone covers being from your alma mater. Or your, children's best character from Disney. These are really personal devices, and the opportunity to extend the patient-physician visit beyond 8 minutes into the home environment is a very personal thing. So I don't think health IT has to be this depersonalized process, but rather a very personal one. I mean, I can tell you, in my practice, if I want to show a patient something, I use my tablet, and I can sit next to them in the bedside and look them in the eye, as opposed to turning to the side, looking at a desktop or looking at EMR or scribbling on a piece of paper. So these are very personal devices, and I don't think they will replace the talent on this side of the panel.
By the way, you guys are far too passive. I want to see a few hands raised or some comments or questions. I think we have one.
So I think there's a little bit of distinction there between it's clear, right, that I don't think anyone wants to remove the physician from the equation, but there's a capacity challenge that we face. When we talk about 8 minutes per encounter, and we're not putting enough time in our physician system to provide that coverage. Is there some balance that utilization of technology will be able to allow physicians to use their time more appropriately and be better armed with information so that those interactions can be more focused on the things that skills that the physician can provide?
Absolutely. And finding that balance is going to take time. But it is. For example, there are certain parts of the healthcare workflow that need to be extremely personal and other parts that don't have to be so personal. From the moment I decide to get a CAT scan of somebody's sinuses, from that moment to the moment that I have the images and the report in my hand, doesn't have to be terribly personal, right? I'm looking for the most efficient way to get my order to the radiology facility, get the patient there, get the scan done, get it read, get me the images, whether it's disc or online, use both, and get that patient back in so I can talk about it. That little piece of the workflow doesn't have to be terribly personal. But the part that comes ahead of it, where I look that patient in the eye, I talk to him, I touch him, I examine him, and we make that decision together. We can get you a CT of the sinuses and see what's going on. That's got to be extremely personal, right? That's decision making, and we're looking for subtle cues, right? If I'm trying to figure out if a patient, say, needs sinus surgery or not, okay? By the book, there's a fair amount of leeway there, right? You can argue for many patients, yes, they need surgery, no, they don't. So how do you make a decision? Well, the way I do it is I kind of float the options out in front of them, and then I'm looking for a look in their eye, right? I'm looking for, did they look at their spouse sitting in the chair behind me who's in the exam room? Did they look at each other with a knowing look, with an alarmed look, or something like that? And there's no computer that's going to read those cues. And so, if I mention it and they get a big look of relief on their face, it's like, we've been waiting for somebody to tell us that. Okay, we know to get more aggressive with that surgical option. If I look at them and I get a deer in the headlights look or a scared look, okay, back off. Let's come up with something else. But that's the kind of stuff. We need health information technology to get the drivel and the white noise out of the equation so we can concentrate on that stuff.
Absolutely. That's a terrific question, and I think part of that is what he commented on, but also in terms of the personalized experience for the patient. So data, analytics, that's where health IT comes in, and being able to, as a physician, give them personalized treatment and assessment plans based on all this data that I didn't previously have, or that I spend large amounts of time getting before I walk into the patient's room. I mean, the typical workflow for a physician before they go in to see someone in their office or even in the hospital is just getting, okay, what's their past medical history? How many scans have they had? What's their lab work? All of that is a lot of time, more time than the 8 minutes, to the point we were making earlier. So if some technology put that together for me, gave me this holistic view of the patient before I walked in the door, then I get to have that more personal interaction of, okay, you have arthritis, you've been having joint pains. Where? Mornings, evenings, up the stairs, in the car, all of the things that are clinical indicators for me that help me determine, is this osteoarthritis, is this rheumatoid arthritis, or is this lupus? But the problem that happens now is I spend more time getting that information together than having that conversation, which is much more telling and influential in coming to a clinical decision and treatment plan.
But I think the change that's going to happen in healthcare is the consumer/patient, whichever they are at the given time, is going to start driving this a lot more. So it's not about me walking into your practice for an appointment and your office staff hands me 4 pieces of paper to fill out my medical history that I scribble down, which, by the way, my hands are killing me because I have arthritis and I can't really scribble it down. Not to mention I can't really remember when I had my surgery or when I've had all these informations, but I'd rather flip my piece of paper over, scribble it out, write down my Microsoft Health Vault account, and the nurse and the clinical staff or the administrative staff looks and goes, "What are you talking about?" Well, there, go to Health Vault, type in the information, and you will get access to. Well, we don't do that here. And it's just back and forth. So at what point is there a give and a take between what the physicians are used to and what they would like to see? Because I can give all that to these 2 doctors in a heartbeat, right? If I do my part of the equation, right, and create that engagement between the practice as well as the patient. So it's an interesting time where are we going to wait for the physician to say to me, the patient, hey, you should use this thing online because it can really help, which brings some value? Or is it the other way around where I'm just going to sit there and go, no, here it is, here's my account, and I'm not writing this down. So I think it's an interesting time right now.
Other question?
Hi. I'm going to back up to something we were talking about a few minutes ago, and I guess it's less a question, it's more of a sort of request or a plea, if you will. And it might spur some conversation, I hope it does. But I'm a designer. I do user interaction design for all kinds of medical apps and mobile medical and all the rest. And if it weren't, and my background is not in medicine whatsoever, and if it weren't for the physicians that we work with and the advisory panels and all that kind of stuff, I'd have no hope of making anything remotely useful, and I know that. But the challenge and I think probably I'm speaking to the wrong people because you probably are engaging exactly the right level, but you've got these people who come in and they come to us with solutions. I need this button here. And I'm like, okay, back up. What do you actually need, right? And so there's these conversations around that where there's, understandably physicians who've had horrible solutions dropped in their laps, and they want better solutions. And in their heads, of course, they have better ideas for how to fix this, And the more, and I think I do get the sense that you are doing this, but the more you sort of contribute in your workflows, your needs, all the stuff you've been saying right now, that kind of allows the designers and the people who are trying to create something out of this to sort of optimize the whole thing for each of those individual bits and pieces. Is that making any sense? Or
No, it absolutely does. And again, I think that's exactly what we're saying is that this can't be done to physicians or to patients. This whole transformation has to be done with physicians, with patients, with nurses, because that's the only way the design is going to make sense. And this is almost 100% design. It's got to work. It's got to be sleek. It's got to be efficient and really connect the points that need to be connected. But you're right. And so as organizations, as all of you in the audience come from different walks of the industry, I think that's why I have a job, right? That's why AT&T has a physician. That's why provider organizations have someone like this gentleman and chief medical officers and chief nursing officers and physician champions and patient champions. So as you look at the resources you have to invest in as you're developing these technologies, you need someone to sit down with you and say, hey, this is what's not working. This is my idea, but I'm just a physician. I don't know IT, but since you know design and you know IT, let's make this work in a way that you won't have 50 more physicians knocking on the door saying, hey, this doesn't work. I have this kind of idea. So I think that, again, as everyone comes from different walks of the industries, it's just really important to keep that clinical view and perspective in the mix. Otherwise, you're just really spinning wheels.
I would say if the physician wants that button, I would consider giving it to him. Even if you think it's a bad idea and you know it's a bad idea and you know it doesn't make sense, I would at least offer that option as part of a bigger conversation. Because what you'll get, because I'm in the same situation. I design templates for our system. Our EMR has a proprietary programming language, and I write the code for it. And so yes, within templates in our system, I can start with a blank sheet of paper and put those buttons anywhere that I want them or the docs want them. And sometimes you just have to indulge, because if they get their button and then they go, yeah, you know what, that really wasn't such a good idea, not only do you give them some sense of control, but they also buy into your expertise as a designer.
And they're out of budget. And then you can't go back and fix it because you've already spent your budget. I would actually ask when you talk to that physician, ask him if you can go to surgery with him and get some feedback to his expertise. And see how that conversation goes.
There is an asymmetry here. See, I got to disagree with you there rather strongly, because there is an asymmetry here. It's not the same. Doctors don't think they're programmers, and if you go to that doc and say, let me come to surgery, tell you how to operate, you're going to turn that doc off. They are never going to listen to you again if you get up with that kind of a challenge. So what I would say is have the conversation, show them the bigger picture by all means. But there is an asymmetry here, because physicians share the final responsibility for patient outcomes, right? In the end, this is our deal, and that you may not want to hear that, but in the end, we are the ones that are responsible for the outcome of patient care in the end. And you can go ugly and talk about malpractice liability and all that. I'm talking far bigger than that. We are our own worst critics. We are our own hardest judges, and we're the ones that have to be the final filter for what is actually used to touch patients.
So again, this really can't be an us against them, right? It's got to be done together, and I would say that before you build something, right, someone, whoever the decision maker is, should have had a clinician working with you as you're developing the design from the first place, to avoid the budget issues, rebuilding something, then having the end user say, hey, it doesn't work, or here's a button. And again, I think, again, that's why these roles are coming about within the industry, because people are realizing the end user is very critical and not something you can throw in at the end of the equation. If you are the end user, and just like Alex was saying, as a designer, whatever technologies you use to do your job, you wouldn't want a physician to design that, I'm guessing. And so physicians don't want to be using tools that are designed by non-physicians. And that's really the whole point here, is we have to bring it back to that. But this really can't be done without that perspective. It won't work.
Yeah, very, very important point. And I love this panel because I have never been quiet for 15 minutes before. But that is a huge point. The product that we have was designed by physicians. The product that we acquired was designed by a hospital group with physicians and engineers. The irony of things is when we talk about a shortage of caregivers, now physicians are getting so frustrated that they're starting to realize that they can make a bigger impact outside on the vendor community than actually doing it, taking care of patients directly, because the system is really making it very difficult for them. The good side of that, in our case, we have physician founders, we have physicians on the board, on advisory board, we have subject matter experts. We work with the customers on everything that we do. But also, physicians are leading the whole customer-facing transformation, implementation, and everything, because we need to work with those physicians, definitely. But one thing I wanted to mention is when we get somebody asking for one button that has to be added to the system, what we do is we bring a group and we start talking. And we need to realize that it's not just about that physician, it's about the care coordination team. And we all have to start looking at how can we do something that benefits, that bottom looks a little bit different for every one of the care coordination team, because they have to look at data differently, but at least there is some sense on the way you design it. You started it.
Exactly. Yep. And the problem, I'll tell you, the problem that your doctor had is they just wanted to see a patient. And they were looking for the easy button from Home Depot, or Office Depot, sorry. Staples. Yeah.
I don't know, I'm really going to question myself when I go to Home Depot for a drill.
Hi, Suresh Srinivasan, Emergency Medicine, CMI, Children's Hospital, Detroit. I spend a lot of time enabling providers on EMR upgrades and the like. And this question, sort of a comment, is for Alan and Geeta. With mobile health solutions, it's a little bit easier given the relative coolness of the products, and physicians and nurses are more engaged. But I think the engagement takes place in meetings and boardrooms, etc. I think for the Airstrips and the AT&Ts of the world, this will make a huge difference if you guys didn't spend time with the physician in the ERs, in the ORs, in the inpatient units, and in different clinic practices. Because the problem I see is not technology. The problem is not bandwidth. The problem is not font size on the tablets. The problem is workflow. And your points on workflow are well taken, but I think the engagement can be broader. It could be earlier, and it could be much more wider. Thanks.
It's a great point, and that's exactly what we do. That's why we have physicians engaged in every step of the process, because you need to see the workflow on a daily basis, but also you need to design dashboards that show you the impact that you bring to them on their workflow on a daily basis. So they can see how many patients came in with this condition, what was the benefit. You have to show the benefit every day for them to realize that it is worthwhile using this.
Suresh, thank you for the question, and you're absolutely spot on. Again, at AT&T, the first Chief Medical Information Officer for the company, a practicing physician, which was really important for the company as well, and so not to just say, hey, I used to see patients once upon a time, but to actually be able to say, well, last week, I still practice, this is still very real to us, and we are very much looking to develop and continue to develop real solutions that work in today's environment. We have a HEAC, a Healthcare Advisory Council, made up of CIOs and CMIOs from the provider side, and we do just that. We work alongside them. We say, hey, listen, you're in the cone of silence. What's going on in your ER? How can we help? And we'd love to talk to you after if you're interested in also working with us. But we have clinicians, doctors, nurses, C-suite executives, and just, again, normal day-to-day doctors and patients that help advise us all the time and bring that lens to our products and solutions.
Right. Just to follow up on that, I think there's an opportunity here in the mHealth world. Going back 5 or 10 years, I work in a hospital, pretty good EMR, stage 6 HIMSS, etc. But I've never had anybody from that large EMR company shadow me for X hours to figure out, what could have been done in the first place, so that they can show the impact what Alan was talking about. Thanks.
So if that's an invitation, I'll get your card.
Sure.
Be happy to talk to you.
Same.
Thanks.
Hi, Keith Salzman. I'm a CMIO at CACI, and I retired from the Army as an informatician and family practitioner. I think to connect the dots here, there's a whole transformation and workflow change that has to happen, because the EMR brought in more work for the physician with less return on that work. You can drive that work into the workforce, your clerks, your medics, your nurses, to be collaborating on the team to gather information and reduce the work of the physician at doing that, and focus it on decision making and managing care more effectively. And I think that there's an enabler in EMRs, there's an enabler in these technologies, but if you don't take what the physician doesn't have to do and redistribute it in the workforce, the other part of that is that the unemployment rate in America begs training of people to fill in these jobs where there's a need, because you have a growing service industry that's not educated to take these jobs. And if you start educating them to fill in that workflow, then you both address the unemployment problem, but you also address the shortage of physicians and healthcare providers.
Very good point. And first I want to thank you. Retired Colonel Keith Salzman, he just retired from the Army, and a year before retiring, he decided to go back in the field, in the battlefield, and be in the trenches with the soldiers even though he was at a very senior level in his career. I have never seen that happening before, so thank you very much, Kit. Thank you. And I think it's a very good point, because if you look at those organizations that right now are laying off people on the inpatient side and you ask them, who are you laying off? Well, case managers that were working on the inpatient side, but what about physicians? And now we want the physicians to engage more with the patients. The reality is they need to redeploy those people to work as case managers, working on the ambulatory side, and potentially hire more people to be able to manage that patient population. Everybody talks about physician and patient engagement, but everybody forgets that there is a human capital in between that has to help those physicians to make this possible. And the healthcare organizations are contributing to the unemployment, but not recognizing that this is a huge issue.
Hi, I'm Raquel Bartz from Duke University. I'm a practicing physician. One thing that I've noticed in this space is that even within our area of the triangle, it looks like the private hospitals are actually moving into the space quicker than the academic medical centers. Where do you guys see the academic, which I consider a threat, because once you end up using analytics, all that real-time data, all of a sudden these private groups actually have more data than the academic medical centers, and I think that's where some of the real ROI can end up existing. Where do you guys see the academic medical centers in this space?
I would like to mention just a quick thing. So I always say that the visionaries of today are the large enterprise networks that need to figure out how to manage population health throughout multiple areas. I think that the academic medical centers are no longer the visionaries, but what they need to do is they need to go back to that stage, because you're taking cases that nobody else is taking, and you need to be able to collaborate with those organizations, because you bring something that nobody else has. But without that collaboration, now it's not going to happen.
In my market in Atlanta, Emory is one of the major forces in that market, but it's not the only force, and there's also a few non-academic players that are there. I think the academicians have a certain disadvantage because they're so big that it's like trying to an aircraft carrier to get things to happen. But I think in most markets, I think at Vanderbilt where I trained, that the academic center is a big player. But I think they're a big player, but not the only player.
I think in academics, and for academic medicine, it's also about what motivates the organization, what's driving the organization. So clearly research is a big part of what's happening. And, for example, Johns Hopkins, it is a tripartite mission. So we aren't just clinicians, but we're clinicians, educators, and researchers. So I think that makes it a little bit harder than if you were a community-based hospital where they're gathering that data. But we're trying, and we recognize that, especially for our growth, that we now have these other entities as part of our integrated network. How do we bring that data in? So I think that's the big struggle, because of the size and because of the different types of mission, it makes it that much harder.
And I think the question, that was a terrific question. I think that's something that the AMCs have to think about. I definitely think that health IT is going to be a competitive advantage, whether you're on the private side or the academic side. And in some cases, AMCs are much more well-positioned to do some of this because they have the capital to, in a way that smaller community hospitals may not. But it all depends on your priorities. But I would say to anyone in the audience that's thinking about 2013 and beyond, IT is definitely going to be a disruptor and definitely going to be a competitive advantage. And it's going to be a real part of whoever is still left in the landscape.
In back first.
I represent a nonprofit organization that is working with Spanish-speaking population in Oregon. We have a patient navigator program. We are helping these patients dealing with comorbidities, some of them with a lack of insurance, some of them with insurance that they don't understand how it works. So we are trying to connect dots and help them also, with some adding cultural sensitivity to them. So we are here because we would like to add some kind of technology to our process of navigating with them, because 50% of them live in the rural areas and the other 50 in the metropolitan areas. Do you have any advice about how to add technology to our programs?
Definitely. Again, thank you for your question. in the emergency room taking care of homeless people at a large academic medical center, I can't tell you how many of the people in that patient population have a better smartphone than I do, and a better tablet than I do, often because they don't have homes, right? Often because they are an indigent population for which devices are actually their hub. And so I would say that, you're definitely looking in the right space. Technology is absolutely something that is made for that population as well. Again, we've invested in several pilots. One of them was with a Medicaid population, and we saw terrific results with regards to patient engagement, sustained interest, outcomes. So I definitely think it's a way to go as you're looking at how to better improve that population.
One of the questions I was curious about, well, is from a standards perspective, and I wanted to use an analogy. When I buy a product for my Wi-Fi, the house, whatever, there's certain standards that I know that I can kind of leverage that helps me kind of make decisions as to what I want to buy. From a patient perspective and also from a provider perspective, are you seeing standards that can help patients navigate kind of the exchange of information between a provider and themselves as part of how we provide information to them and how we may get information back? And are those standards established well enough to be able to have a level of competence in doing that?
So of course, let's look at, I'm always going to talk more about the provider side. And the first thing that we looked into is the FDA as having a significant role in remote monitoring, because if you're a patient, you want your doctor to be able to look at the data in the best possible way with diagnostic quality. So we are a big proponent of FDA clearance for medical device mobility. But then also, you need to look at the FCC and the security standards. Today, the Open SSL standard is not enough, so we have to go beyond that and looking at encryption at the transmission side, client server, being able to do dual authentication, the same way you do your bank statements with a soft token instead of a hard token. And then, so that's just for protection and protection of the diagnostic quality. But then if you look at healthcare information exchange, that is the big challenge that everybody's dealing with. So if you look at every organization, you have to realize that there are going to be a number of standards that people are going to support. In some cases, people are going to give you data on an HL7 format, which is a transmission protocol. TCP/IP, you have application layer protocols for HL7. Then you look at continuity of care documents, a subset that comes kind of like it's similar to what used to be a PDF, but at least you're getting some information. And then you look at other vendors that do not support any of those standards. So the standards exist, but people are not complying with them. And at the same time, the government is making a huge effort to create a federated module, a model to be able to route data, warehouse data, and do an enterprise master person index to identify the patients. So they are there, we're getting there, but we all have to comply with them instead of find shortcuts.
Hello, I'm Samira Scarpa. I work with Aegis.net. We've been talking about mHealth or electronic healthcare for the past couple of days as means to ensure some cost efficiencies or improve patient experience. But I'm wondering if it could also be leveraged as an opportunity to create new revenue streams for private practitioners or hospitals. And first of all, I'm wondering if you think there are any barriers to that. And second, if there are not a lot of barriers, then whether something like that can actually scale.
I think the biggest barrier has to do with the third-party payment system, because right now you have an environment where nobody is paying for any patient encounters unless the patient comes to the office. So, of course, we're going to want to drive that. We have to. We don't like it. I mean, there's a lot of things, a lot of my follow-up visits could be handled with, an email or a secure text or a phone call. But right now, we're locked into a third-party payer system where not only are the third-party payers not paying for that stuff, but it's illegal for us to balance bill above and beyond that. If you try to bill a Medicare patient for a phone call or an electronic encounter or something like that, you may run afoul of the law. So we are pretty much, and that's a pretty bad barrier.
But 16 states actually do allow for So there is some starting to shift a little bit at the local state level, but not across.
There are also several concierge practices that have developed like this.
So do you see, just a quick follow-up, do you see people being willing, maybe upscale patients being willing to actually pay for extra like VIP service or?
All about value.
Absolutely. Again, there, I think, are a number of concierge practices that have popped up because of that.
Hello, thank you. This has been excellent. Eric Brown from Molina Healthcare. I'm just curious, there's been a lot of discussion about patients driving change and providers driving change. And since part of our business is as a payer, I'm a little leery of asking the question in light of your comments, but I'm just curious about how you see payers playing in this space in terms of driving change and use of mobile devices in the future. Thank you.
Well, they just have to be flexible enough to pay for those services. I mean, it's starting, and that's good. But they don't really have an incentive to expand it. Is the problem? Is if you're Blue Cross or you're Humana, what's your motivation for offering that service when your relationship isn't with the patient, it's with the employer? And so that slows it down. It's not like they can market. There's not enough of an individual patient market to go out and say, well, yes, it's going to be worth a few dollars extra for an insurance premium for X health care because we're going to give you more in exchange for that.
And I know she's going to give us a good answer.
I have to respectfully disagree. I think there's a lot of incentive on the payer side, and it's coming from the employer, and it's going to be coming from the consumer as well. There was just a big story in Wall Street Journal and New York Times about what the payers are doing to prepare to directly market to individuals. And I'll tell you, if I get a health plan that requires my provider to have an EMR and allow me electronic access, I'm more likely to choose that one than I am the one that doesn't. I'm more likely to choose the provider. And on the employer side, employers, most of whom are self-insured, are demanding healthcare costs be pulled into reality. And one way to do this, it is going to be somewhat lower cost to have you do a 10-minute interview or 10-minute office visit via teleconference or email to do that follow-up visit, so freeing you up for other things, freeing your staff up for other things, and that's going to should drive down costs.
And I agree with you, and I think that gap is really getting much better. You even see right now payers buying providers, physician groups. So this is already happening. They already see that there is a benefit of working closer with the providers, but it's going to take a while for them.
Well, go ahead.
We're bumping up near the end of the session here, so let's try to finish off.
My only comment with the payers is that they've got a lot of data as well. So if they become part of this process that we've been talking about, they can help with outcomes, they can help show results, and as part of it show the value there, value to what they're trying to provide and try to sell to the employers, value to the organizations that's trying to find the outcomes that we've been talking about earlier. So it is part of the partnership.
Just one more thing to your comments. Accurate, but many are theoretical, especially the need to drive down costs and the assumption that bringing technology into the game is just going to automatically drive down costs just because you buy the system. I came across a study tinkering around last week. There was a study of Kaiser Permanente, Colorado, and they compared, and this is a flawed study, but it makes good food for thought. They compared patients who used the web portal versus patients who did not use the web portal to access their records remotely, and they found that the web portal patients had a far higher rate of office visit, rate of hospitalization, rate of late clinic visits. It's a paradoxical thing, and this gets back to the unintended side effects of technology, which is that just because you buy the system and put it in, and this comes from the top down, that it's an automatic, that it's a no-brainer that it's going to reduce costs. That has not been proven, and there's 3 or 4 studies out there I can give you that show that the opposite happens, that utilization goes up, admissions go up, office visits go up with patients who are using a portal. Now, the flaw to that study is if patients using the portal might be sicker. So I'm not saying that that's a gold standard study, but I'm saying that you can't assume automatically that because employers are going to insurers and saying we've got to cut costs and throwing technology into the equation just for its own sake, they'll do it. Yeah, it's finding the appropriate way.
So, Deborah, thanks for the question. I think Deborah and Craig hit on some things, and on my last comment, Eric said I can talk for 2 seconds. AT&T has 1.2 million employees. We rolled out our Diabetes Manager product with our own employees and found, again, that the outcome showed improved patient engagement, improved sustainability, people who are saying, I'm going to use this thing even beyond the pilot, and I'm going to recommend this to a friend, and so on and so forth. So I definitely think there's a space for payers. I think there's a space for employers with the hope of achieving reduced outcomes, with the hope that diabetics don't end up in the emergency room, and instead, because of some of these sponsored applications or mobile health applications, are able to reduce that. So I definitely think there's a market for sponsored mHealth apps in the future.
Michael, Gita, Alan, Alex, thank you very much. This was